Thank you for that wonderful introduction. My name is Angelique Tay. I used to be a resident with Dr. Shabink. Um, and I'm here to talk about the systematic review of negative brain MRIs in patients with CSF venous fistulas. I remember when I first started liking CSF leak, and I went up to Dr. Shabink when I was a budding neurosurgeon, and I asked him, Dr. Shabink, what is your diagnostic pathway for these patients? And he goes, Angelique, it's all in here. So I went to do my research and try to figure out my own diagnostic pathway for this, and it kind of spurred a lot of research with him. So I mean, we all know this. We've been talking about it for the past 2 days, but patients by and far usually show up with orthostatic headache. They get an MRI brain with and without. And if there's a positive brain MRI, then we go for MRI myelogram. If there's extradural CSF, we do a prone DSM, we find the type 1. And then if there's no extradural CSF, then we do a lateral DSM and we're looking for a fistula. And by now that's pretty obvious, but, um, the question I had when I was more junior was like, how many patients with positive brain MRIs actually are found to have CSF leaks? And, there's a lot of literature out there right now, and mostly basically 75% of the time, you either find a ventral leak or a CSF venous fistula, either with a DSM or a dynamic CTM. But then my question was, what if the brain MRI is negative? What do we do with those patients? And we go for MRI myelogram. If there's an extradural CSF, then we do a prone DSM and we find a type 1 leak. And that's pretty obvious now. And in the literature, we think about like 20% of patients with a negative brain MRI and extradural CSF leak end up have a negative brain MRI. And that's not surprising. But then what about those without an extradural CSF fluid collection on the MRI myelogram? How likely will you find a CSF venous fistula? Well, we went through 5 databases: PubMed, Embase, Web of Science, Scopus, and Cochrane, and we searched CSF venous fistula and spontaneous intracranial hypotension, DSM, and brain MRI, and we found that we 586 papers. After the exclusion criteria, you took out 37 papers for positive brain MRIs or a intermediate or high probability on burn or Mayo scores, or if there were no CSF venous fistula patients, or if no brain MRI was reported, or if no leak type was discussed, and if the CSF venous fistula was identified first before they looked at the brain MRIs, or if there's overlapping patient cohorts, or the DSM or dynamic CTM was not done in lateral position, so considered not to have the gold standard imaging. And we resulted with 9 papers. And in those papers, what do they consider a positive brain MRI? Well, typically they went with the SEEPS scores. So subdural fluid collections, enhancement of the pachymeninges, engorgement of the venous structures, pituitary hyperemia, and sagging of the brain. Um, and then 4 of the papers went with the burn score. And I think by now we all know that one. Subdural hematomas, pachymeningeal enhancement, venous distension sign, and then brain sagging with the measurements of MPD, supracellular cisterns, and prepontine cisterns. And then there's the Mayo score, that's more recent, and that one looked at the pachymeningeal enhancement, venous distension sign, the pituitary enlargement, and also supracellular cistern effacement, and so cerebellar tonsil herniation. And a couple of more points in there that the burn score doesn't really have is the dural enhancement in the IACs and the supraqueduct icter below the incisional line. So what did we find? We found in the papers, 4 papers that looked at MRIs and categorized them as entirely negative or positive. There's 252 patients that were entirely negative, and 27 of them were positive, 10% of that. And the other thing that is noted there is that a lot of these papers did not use the same imaging modality as their gold standard. So there's a lot of lateral DSMs, decubitus CTMs, cone beam, photon counting. I'm not a radiologist, so I defer to them to say which one's better. I think that's still in the controversy. Um, and again, that's 10 to 11% of the patients that were considered negative brain MRIs were found to have CSF venous fistulas. For the burn score studies, 4 papers, 82 patients total that had a low probability score, and 15 of those patients, so 18% of the patients were found to have CSF venous fistulas. And then if you look at the Mayo score, 109 of those patients had a low probability according to that score. And 38 patients were found to have CSF venous fistulae. And there's an asterisk there because it was actually 43 patients, but the categorization of whether those patients had CSF venous fistulae or type 1 was not sure for 5 of those patients. So we took the conservative measuring, just removed those 5 patients. And ultimately, what we found is, if you look here, that the negative predictor value of these scores and studies. So if you take the 4 papers with the MRI categorized based off of entirely negative or any positive signs, if there's an entirely negative MRI, 90% of those patients did not have a CSF venous fistula. So the predictive value was pretty high, 89%. For a burn score, it was 81%. And then for the Mayo score, it was 65%. So what questions arise from this data? Well, there's 2 outliers here that we're to look at. And why are there these differences between an entirely negative brain MRI and a burn or Mayo score of 0 to 2? So the first thing about these outliers is that there's no true gold standard for detection of CSF venous fistula. Aside from the DSM, different techniques for the dynamic CTM have been evaluated in the literature. There's differences in how these images are captured, the timing of the contrast medium injection, the type of anesthesia done, sedation versus general anesthesia for clear images, whether or not the saline is injected for positive pressurization prior to myelography, and whether respiratory maneuvers are employed during image capture. So one of those outliers had an interesting technique of combining modalities to increase diagnostic yield using DSM and cone beam CTM. They had 100 patients, 15 were excluded for extradural CSF, or patients that didn't meet SIH criteria in the ICDH criteria, did not undergo both imaging modalities, and they were left with 85 patients. Oh, sorry. 38 of the patients were found to have CS venous fistulas with after DSM only, so about a 45% diagnostic yield. And if they also had cone beam CTMs after, the diagnostic yield increased to 69%. And how many of these patients actually had a negative brain MRI? Well, if you took those 85 patients, you split them up, 25 of those patients had negative brain MRI, and 6 were found to have a CSF venous fistula, so about 24%. 4 of those patients were only identified after they had both imaging modalities. So it kind of raises questions about maybe we should be combining these. And then the other question we had was, why are there differences between entirely negative brain MRIs and burn or Mayo scores of 0 to 2? Well, first, the burn score was actually developed to predict the likelihood of finding an epidural leak on spine imaging, not likely entirely applicable to CSF venous fistula patients who don't usually have those SLECs. The Mayo score was developed with only patients without SLECs, but they also could include a dural tear with a small localized extradural fluid collection. But I think the major difference is the fact that having a low burn or Mayo score of 1 or 2 is not equivalent to entirely negative MRI. And not all the points in these scales are equal. And what do I mean by that? There was a recent paper by Kane et al. Who looked at 90 epilepsy patients, and they chose epilepsy patients because they have MRIs equivalent to SIH patients that were not clinically suspected for SIH. The average burn score was actually 1.5, and the average Mayo score was 0. And what's interesting is if they stratified these patients by low, intermediate, or high, there was actually 20 patients with the intermediate score. So where is these points coming from? And when we looked at that, the points are actually coming from the measurements of the prepontine cistern, the suprasellar cistern, and the minimal pontine distance. So maybe patients at SIH, we should be putting more weight on the subdural fluid collections, or the pachymeningeal enhancement or venous sinus engorgement that isn't found in these patients without SIH. So back to the original question, what about these patients with a negative brain MRI? If there is no extradural CSF venous fistula, how's the likelihood? If there is no extradural fluid collection, what's the likelihood of finding a CSF venous fistula? So in the end, we found that if there was an entirely negative MRI, 89% chance the patient does not have a CSF venous fistula. If it was a burn score of 0 to 2, it's 81% chance. And if it was a Mayo score of 0 to 2, it's 65% chance that the patient did not have CSF venous fistula. However, While this is a very good and negative predictive value with an entirely negative MRI, if there's still high clinical suspicion of SAH, we would still recommend proceeding with the lateral dynamics CTM or lateral DSM. So when do we proceed? Again, the high clinical suspicion, and as mentioned earlier by Dr. Schmink, the presence of meningiodiverticuli on spine imaging. It was shown in previous papers that 20% of the patients positive for meningiodiverticuli were found to have CSF venous fistula, but if they had no diverticuli, they didn't have a CSF venous fistula. The other thing we look at is the reduced optic nerve sheath diameter, which could increase the chances of finding a CSF venous fistula in a patient with a negative brain MRI. We found that if you did a cutoff of a optic nerve sheath diameter of less than 4.4 millimeters and a perioptic subarachnoid space of less than 1.0 millimeters, you found CSF venous fistulas in about 50% of those patients. And if they had values above that, less than 2% of those patients would have a CSF venous fistula. So if if optic nerve sheath diameter abnormality was considered a positive MRI, there's a chance that the negative predictive value of a negative MRI would actually go up. So this is what I ended up with in my diagnostic algorithm after talking to Dr. Schmink. If there is no extradural CSF venous fluid collection in a negative MRI, then if there's a high clinical suspicion or an optic nerve sheath diameter of less than 4.4 or a perioptic subarachnoid space of less than 1 millimeter and meningeal diverticuli, then we would proceed with a lateral DSM or dynamic CTM. And thank you. These are my references. And I especially wanted to thank everyone who helped me with this, which was Dr. Madavan, Dr. Cross, and Dr. Maya, and Dr. Shudink. Thank you.